They end up, gaslighting you, and now, now you feel even worse than you did before. And now you have the medical trauma on top of everything else. But we have this conversation that you and I had in the past about pain begets pain. I wonder if also trauma begets trauma. Like if you have had more trauma, does that then make you more sensitive to future trauma? Welcome back, every bendy body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained expert in Ehlers-Danlos syndromes. I'm joined once again by my friend, colleague, and recurring co-host, Dr. Dacre Knight, Medical Director of the UVA Health EDS and Hypermobility Disorder Center. Through our ongoing partnership with UVA Health, we're bringing you practical, evidence-informed strategies that improve the everyday lives of people with joint hypermobility, connective tissue disorders, and related conditions. Today, we're going to be answering some of your questions. We'll be talking about tongue tie, pregnancy, menopause, hormones, local anesthetic, systemic toxicity, and so much more. This podcast is for education only and is not a substitute for personalized medical advice. Here we go. Well, I'm so excited to be back with Dr. Dacre Knight, who is the Medical Director of the UVA Health EDS and Hypermobility Disorder Center. How are you doing today?
It's always a pleasure to be here with you, Dr. Bluestein. Thank you so much.
Yes, absolutely. So we're going to address some fan questions today. We get so many great questions, and I do want to tell people before we even start on this, please send your questions to bendybodiespodcast.com. And when you're there, you're going to notice that the website is a little different. There's some enhanced search features, and hopefully it's going to be easier for you to find transcripts. The transcripts are hopefully more accurate. We're really working on trying to make this information as accessible as possible. And so please go to bendybodiespodcast.com and send us your questions. We would love to hear from you. We want to answer the questions that people are most interested in. So we're going to address some fan questions today. Dr. Knight, if you have other questions you want to throw in here, I have some already written down, but you're welcome to, if there's things that you're like, oh my gosh, this past week I got asked this thing 5 times.
Well, in my experience, the fan questions have been very good, so I think we'll have a lot of material to go through.
Yes, most definitely. Okay, so the first fan question is from Samantha. Samantha says, I was just evaluated for a tongue tie and am pursuing a release. I welcome any improvements to my quality of life. I've read about EDS folks having this done and having fewer headaches and migraines, less coat hanger and neck pain, and less TMJ-related issues, just to name a few benefits. I was wondering if you could do an episode on adult tongue tie. And just so you know, Samantha, this is not going to be an episode on tongue tie. This is not going to be, people with super high-level expertise on tongue tie. We're just going to kind of cover this on a more broad level and speak from our experience. And I also want to mention that if anyone knows somebody who would be a great guest for this topic, please go to bendybodiespodcast.com and send us a message. It was mentioned in the most recent fascia episode, which sent me down a rabbit hole. I listened to a podcast from a pediatric chiropractor who said tongue and oral ties are a secondary compensatory downstream issue of a primary dysfunction of subluxation of the nervous system. Quote, dysautonomia. I found that fascinating, and it only heard him link it to nervous system dysregulation pre-birth. This tracks for me personally. I'd be very curious about what you have to say. Thank you. A lot of different things to potentially unpack here. I'm going to let you go first. I'd love to hear what you've heard about patients with tongue tie, what your experience is, if some of them have had release, and then also this very interesting comment that she is making that something she heard from a chiropractor.
Yeah, it's a good question, Samantha. And I would love to hear what other, maybe experts in this field, otolaryngologists or oral surgeons have to say, because I haven't really thought or heard too much about it until actually recently. This topic did come up in a conversation with some other colleagues of mine, and the condition of tongue tie, ankyloglossia, which is it seems benign or not really an issue until maybe it is, but we do encounter issues with patients with EDS and hypermobility problems with swallowing difficulties and dysphagia and anything in between breathing issues, things like that, sleep apnea. Maybe there's some involvement there. And the data is not really strong on this in this group, though, and there may be certainly some research opportunities to dig in a little bit further to understand how different cohorts of patients with those with and without these conditions, or those and with the conditions with or without tongue tie, and see how it plays out. And then in a question about tongue tie release, surgical release, which actually is pretty minimal intervention, is usually pretty quick healing process. There's not much vasculature, the frenulum underneath the tongue, if it's done correctly. But any time that there is surgical intervention, we're cutting tissue in patients with connective tissue problems, obviously there is a little bit of extra concern just how they're going to heal. So I would, in my personal practice, I would be hoping for having a little bit better data to know that tongue tie release is really going to contribute to better swallowing and breathing and things like that before I kind of wholesale send patients to a surgeon to investigate it further. But I can see where it could be a good opportunity for further investigation.
Yeah, and it's interesting because we also know that changes in the frenulum, the absence of the inferior and lingual frenula, are also findings in people with EDS that can be considered diagnostic, at least in some. There's a paper that talks about this, using it as a diagnostic criteria in French patients, that I came across when I was kind of looking some things up for this conversation. So it is so fascinating to see these things that are potential variants, or maybe they're more common. I wonder if we could comment too, though, on some of these things that are more common, and if we think that hypermobile EDS and HSD are actually quite common. It's true, isn't it, that it's harder to actually demonstrate that those things co-occur more commonly than if you're trying to associate two rare things from a statistical standpoint, from a research standpoint. If you were trying to show that people with, I don't know, some weird change to their fingernails are more likely to get, some very rare kind of cancer. Like, I think that's easier to demonstrate than something hypermobility spectrum disorder, hypermobile EDS, which we know are much more common in the general population than we ever thought. And so then something like tongue tie, which I believe is also quite common, might be hard to demonstrate if that's more prevalent or not. What do you think about that?
Yeah, well, that's right. And we also run into so much confounding with patients with EDS and hypermobility problems, because there's certainly many other reasons why someone can have problems. Like I just mentioned, a few of the issues that might arise: sleep apnea, breathing difficulty, swallowing problems, than just tongue tie alone, right? And so it is difficult when anytime we're doing research on any specific condition or comorbidity or whatever it is that we're investigating, because there's so much overlap between these things. So we have to be, really mindful about sample sizes. Obviously, we want to get the largest sample size possible to isolate for as much compounding and variables and things like that. And it's hard to get large sample sizes at one institution. So you have to think about multi-site studies for these things. And then, if we even do, is this a high priority item to study because we're doing large multi-site studies? Maybe there are some other research interests too that we have before we are going down the tongue tie rabbit hole. Maybe we look at other things first. But, in an ideal world, we have access and availability for all of those questions to be answered.
And I think that the issue is also related to potential fascial connections, fascial restrictions. And I know that this is more anecdotal, but the people that I've spoken to that are maybe in the physiotherapy type space, and as you said, it would be fascinating to get like an oral surgeon's perspective on this. But you also have to be careful if you release a tongue tie and somebody has CCI or craniocervical instability, that you can actually make that worse, is my understanding. I had a patient who actually went to a center in Wisconsin, not far from where I've practiced, and they went through a whole strengthening program of the whole, mouth and pharynx and the tongue and all of that. and then they did the tongue tie, and she had really good results from the standpoint of her sleep apnea and mouth breathing and snoring and clenching and all of that, and then it did not make her neck any worse. So I think there's a lot to consider, and programs that are more holistic like that are probably better than ones that, just snip, snip. And especially if they snip, snip on everybody, you want to make sure that they're being selective in who they do this on and that they understand other ramifications.
Yeah, I know a lot of the tongue tie release happens too in newborns too, when there's concern about feeding and latching difficulties, and so it's it happens in that setting, but it's hard to get research data collected on newborns and infants when you're not able to like, get a whole lot of feedback, right? So we maybe get feedback on the feeding mechanisms and things like that. But when we're talking about like things you mentioned, like autonomic dysfunction and symptoms of CCI and things like that, you'd obviously have to do that in an adult population.
And then she also made the statement about tongue tie being a downstream issue of, quote, subluxation of the nervous system or dysautonomia. So I'm not sure what she meant there by subluxation of the nervous system. Dysautonomia we know is dysfunction of the autonomic nervous system. But have you ever heard anyone talk about a connection between dysautonomia and tongue tie and or, this comment? Any thoughts?
That's the first time I've heard that.
Yeah, yeah.
But there's a first time for everything, right? And we know that dysautonomia may be triggered and may be sensitive to so many other conditions, and so it wouldn't be the furthest thing out there that could be contributing.
Okay, so the bottom line, thank you again so much for the question, Samantha. Bottom line is yes, it might be helpful for some people. The orofacial myofunctional therapy before and after can be helpful in addition to the procedure. Definitely want to assess for TMJ dysfunction, cervical issues, as Dr. Knight mentioned, sleep, airway, disordered breathing, etc. So, okay, love that question. Good to move on to the next question.
I'm ready, Dr. Bluestein.
Okay, great. The next question is from Brooke. Hello, I'm still in the process of being diagnosed, but I suspect I have hypermobile EDS or HSD. I've been listening to your podcast and realizing how many symptoms I thought were random are probably linked. My question is regarding hypermobile EDS in men. I know that women seem to be more impacted by the hypermobility aspect due to testosterone, increased muscle strength, etc. in men. However, I've been looking at my brother, who isn't hypermobile in his joints necessarily, but he has other issues with pain, dizziness, etc., and wondering if he could have it. Is it possible for someone to not be extra bendy, but still have symptoms that point to a connective tissue disorder? And how would you go about addressing that with a doctor?
Well, I love the question because I love anytime there's a discussion about outliers and unusual presentations and features. And it's not to say that men are unusual to have these things. They certainly have them, but we know that time and again these have been studied, and women far outnumber men as far as presentation and diagnoses go. So I think that those groups though that come with unique presentations, whether it's really severe symptoms or severe, surgical complications and things like that. We don't want that to happen, but those groups really inform us a lot because when we're looking at taking men for example, I think the question was raised about sex hormones. There's a unique makeup of male sex hormone endocrinology that is very good for us to learn from and how it presents in that setting. So I think that there's kind of general just genetic differences and developmental differences between men and women that may not even relate to sex hormones. That can be some contributions to their presentation or symptoms. But we certainly know that there are plenty of men with hypermobility and then diagnosis of EDS and HSD. Not as many as women, but I mean, to answer the question is yes, the symptoms could point to a connective tissue disorder in your brother Brooke, and how and to answer your question, how would you go about addressing that with a doctor? Well, I think you start with an initial evaluation as we would with any patient. So talking about clinical history, what is kind of the chronology and trajectory of symptoms, and what does the exam look like? And there's some differences in some of the tissue features we're looking at between men and women, and maybe there'll be some improvement on those in the future when we're talking about things like stretch marks and pelvic organ prolapse and things like that. Obviously, men would not have some of the types of pelvic organ prolapse, but there's certainly enough to be investigated there, I'd say.
Yeah, thank you. And I would add to that, first of all, the things that she commented on regarding, dizziness, pain, those could be related to POTS, right? Postural orthostatic tachycardia syndrome. So, Brooke, we're obviously not going to diagnose your brother. We haven't seen him. We don't know what else is going on, but definitely a person could have POTS without EDS, even within the same family, right? So, we know that POTS can occur a whole lot of different ways, or being somewhere on the dysautonomia spectrum, having orthostatic intolerance or, something like that. And that could be post-viral, as I discussed very recently in an episode with Dr. Stevens. So it is very possible that your brother has POTS or orthostatic intolerance, but does not have EDS or HSD is one possibility. And another possibility is, what did he look like before puberty? Because we know that puberty greatly affects males and females differently, and that males, when they go through puberty, are going to have higher levels of testosterone, and that would be beneficial from the standpoint of increasing muscle mass, which is, of course, not only protective of joints and, potentially protective of, maybe weaker ligaments and tendons and things like that, but also if they have more muscle bulk, their joint range of motion will appear to be less and or will be less. So I think that it would be interesting to know what he looked like before puberty. We can't go back and do an exam back then, but maybe asking some of those 5-point questionnaire questions, can you now or could you ever touch your thumb to your forearm? Can you now or could you ever, do the splits? And some of those kind of questions I think might be helpful too. So let's move on to the next person. This is just a comment. This is from Beth. I'm the mom of a 15-year-old with hypermobile EDS, POTS, and suspected MCAS, and your podcast has been invaluable as we've navigated her care. One of the most helpful concepts has been your 10% rule, that several small improvements can add up to meaningful progress. It's really changed how I think about managing her symptoms. When my daughter is struggling with pain, nausea, migraines, GI issues, or joint dislocations, I no longer expect one treatment to fix everything. Instead, we combine things like heating pans, salt, braces, and ice, and sometimes those small supports together make a real difference. I also appreciated your discussion about the pros and cons of social media. While I always verify what I read, the EDS, POTS, and MCAS parent groups have helped me learn about treatments, products, and important issues to discuss with our providers, like the fact that menstruation can trigger POTS flares. Thank you for everything you do. So thank you so much, Beth, for the kind words. Dr. Knight and I had 2 episodes recently on the men's PMMS treatment method that I talk about a lot. And so, yeah, I love the 10% rule. Do you have anything to add to that, Dr. Knight?
Yeah, I agree, Dr. Bluestein. It's it's like we were talking about recently. There's just the small wins, right? Which I think, Beth, you're touching on, and that's really what we're going for, because I think Beth describes exactly what the reality is for many families managing all these things: HEDS and POTS and suspected MCAS and migraines and stomach problems. So it's really one problem with one solution, right? So it's usually a system that needs multiple small supports layered together. So all the modalities or supplements or anything that we can really dig into, yeah, the 10% rule, I agree. So it's about changing expectations in a helpful way. So we know in chronic complex illness, we often do not find a single treatment that gives 80-90% improvement, but we may find a few things that each help with 5 to 10% better, and those added up over time, can really make it more profound impact. So that's what we want.
Yes, and I do want to add one other thing about flares. I don't know about other people listening right now, but I know for me, uh, as much as I treat people with these conditions and I coach them and I do this podcast, if I get a flare of something, I often forget my basic tools. Like I often forget some of the topical things that I might have, or, using heat or ice. So I think that having your flare toolkit ahead of time can be really, really helpful. Identifying in advance, like, oh, what are the things that I have? What are the things that are, readily available? What are the things that maybe I should purchase in advance or have in my home or wherever I might be living? Because sometimes it's really hard to remember when you're not feeling great. It's hard to remember some of these, little things that we have that we can do.
Yeah, and Dr. Bluestein, I was just going to add one more point too to Beth's comment because I thought it was very thoughtful about social media, and we know we discussed this before and how it can absolutely be a double-edged sword, and what we're doing together with this podcast, it goes out on social medias, right? So there's a lot of good that it can be, and even if I hate seeing my face pop up on my on my feeds every once in a while, but anyway, I know it's there for others, but and it is helpful, but to Beth's point, there's also plenty of misinformation out there that can create anxiety. So this is what we're fighting against. And so, we want to have the good sources of information to be available for patients. So I think the key is not to treat social media as a medical advice, but as a source of ideas to verify and work with your healthcare professional team.
Yes, yes. And we're all always learning, right? We could easily say something on the podcast that turns out to be untrue later. So I think it's so important for people to verify information as much as they can and, get good credible sources and diverse sources. And yes, social media is a very tricky place. That's really funny what you said about your face popping up. I especially felt that way in the beginning. It is a
Yeah,
little it can be
yeah,
jarring.
yeah. And just reminding myself I'm just there to help others. Right?
Yep. Yep,
That's what
exactly.
it's all about.
Yes, yes, and the feedback has been wonderful, so, we definitely want you to keep doing what you're doing. Okay, so, the next question is from Nicole. This is one that probably we both have gotten quite frequently. "Hi, I am an avid listener of the podcast. I have the trifecta myself, plus many comorbid conditions. I also hope to start family planning soon with my husband for our first child. Can you do more episodes on pregnancy with hypermobile EDS, POTS, and MCAS? I have only seen one that you have, and it left me wanting a lot more." So, first of all, I want to say, Nicole, I definitely would like to do an entire episode on pregnancy. If you or anyone else has a suggested guest, Dr. Knight may also very well have somebody that we could talk about, you and I offline. But I thought at least you and I should address this because I'm sure you get asked this question all the time. I know I do. And I was curious how you handle this conversation with your patients.
I do get asked this quite often. You're right, Dr. Bluestein, and yeah, I think we all do, and it's a very important question, right? These are big things that patients are going through, and I do think that sometimes it's neglected, and I think patients are sometimes just told either you'll be fine or pregnancy is on the other end is too risky, so don't even bother, and I just don't think that's nuanced enough, right? And the problem again remains that there's just lack of knowledge to share with patients and lack of understanding out there and sometimes in the medical community. So I think, the first message that I tell patients is that many people, the vast majority with hypermobility disorders and HEDS have successful pregnancies and births. And so the goal is not to create fear, but to make sure we're planning thoughtfully. And so preconception is where that begins. And yes, so working with the obstetrics team or maternal fetal medicine specialist and coordinating with other clinicians if they are helping manage things like POTS and MCAS and so forth. So there's a lot of things that can be on the table, but I yeah, I think that's the way to approach it to start. Let's go with that.
And the big thing that I usually really try to talk with people about is, how are you doing right now? If you're having, high levels of pain every day and you're considering a pregnancy, that's a very different situation than if your symptoms are well controlled, well managed, and you're, wanting to start a family and you feel like you have the financial means, the not that everyone should have to, have a lot of money to have a baby, but we know it is expensive. So, do you have the support that you need? Psychosocially? Do you have the stability of your symptoms, or at least relatively feel like you have a handle on things? To me, that makes a huge difference as compared to somebody whose symptoms are, really, really out of control. It's not to say that the person whose symptoms are out of control, can't have a baby, but adding a pregnancy on top of that would be very, very challenging.
I think the main message I would want patients to hear is that, as I said, pregnancy with HEDS and hypermobility problems, POTS, mast cell, and all that, and it should not be approached with too much fear or dismissal. I think with all the right preparation and teamwork and expectations, I think it can go very well. And as I said, it does go very well for the vast majority of patients. And just a couple of the quick pointers I give is one, if you can get engaged also, as I mentioned, with obstructives, of course, but with pelvic floor physical therapy too, early on or during pregnancy, that's a very good one. And then also just understanding that there may be, things that have been studied, talk about, there may be some spotting that happens a little bit more often in patients with connective tissue disorders, not to any really catastrophic level, but just be aware of that. And then also, labor can progress quite quickly. So be where you're going to be when you're getting ready to be at the time of delivery, right? You're not just off out in the woods, and you know where you need to be. And obviously, if labor goes quickly, I think people would prefer that.
Right, right. Yeah, no, I think that's a good point because it can involve multiple different experts sometimes. So, you might have, in addition to a pelvic floor physical therapist, you might also have a cardiologist involved. That's when I saw my first cardiologist. And when I had my first diagnosis, actually, I got the diagnosis of dysautonomia in pregnancy before I even knew that I had hypermobile EDS. It wasn't until quite a few years later. So when I was pregnant, I did not know that I had hypermobile EDS, but I did go on beta blockers in my pregnancy because I was having so much tachycardia, which, by the way, did not present as tachycardia. It presented as shortness of breath. And I have asthma, so they kept thinking it was asthma, but turned out it wasn't. So anyway, yes, these things are definitely, very multifaceted. And it's also, a good idea to talk to other women who have lived through, pregnancies and, maybe might be similarly situated. Yeah.
Yeah, or different, some, like you said, you had some kind of different scenarios, and so we have to kind of take it with a grain of salt that there are certainly any number of eventualities, but that's why we would want to get individualized care 1-to-1.
Okay, we're going to take a quick break. And when we come back, we are going to address a few other kind of maternal fetal questions. We had a couple other questions related to this previous one. So we're going to take a quick break and we will be right back. One of the questions I get most often is, Dr. Bluestein, what products do you actually use and recommend? To make that easier, I've created an Amazon storefront with many of my favorite products for joint hypermobility, EDS, POTS, MCAS, chronic pain, etc. If you're already shopping on Amazon, I would be honored if you would consider starting through my storefront. It does not cost you anything extra, but qualifying purchases help support the mission of Bendy Bodies and allow us to continue creating free educational content for patients, caregivers, and clinicians around the world. Please visit amazon.com/shop/hypermobility MD to learn more. Thank you so much for helping us continue this important work. We're back with Dr. Dacre Knight, and we are answering fan questions. So we had a series of questions that are kind of related, so I kind of lumped them all together. So the next question is from Macy. She said, I've been listening to your podcast for the past month, and I'm so grateful for your knowledge you share with others. Question for you. Have you noticed any correlation with EDS, POTS, MCAS patients and being born premature? I am curious. I was born 6 weeks premature, only weighing 2 pounds, 4 ounces, and had a lot of challenges throughout my life. I am having a hard time trying to get a diagnosis, but have had years of symptoms. I'd be curious to hear your thoughts.
Yeah, this is a very interesting question, AC. And, I think this does go into a little bit where we're just talking about pregnancy and prenatal care and all those things that can happen uh, during pregnancy. And one of those that is, why we just mentioned pelvic floor therapy, why it's good to do is, trying to avoid risks for pelvic floor dysfunction, pelvic organ prolapse too, postpartum. But there's a question too about, any of those things or having pelvic insufficiency and things like that during pregnancy. Does that mean that there's earlier onset of delivery or premature delivery and things like that? I don't know that there's much data on that. I think it's a good question and reasonable hypothesis. But altogether, I don't think there is strong evidence that prematurity causes hEDS, POTS, or these other things, and vice versa, as far as we know. But it's a very good question, I think, with some good biologic and physiologic basis to it.
And as you said earlier with the tongue tie question, this would be a great thing also to study if we had unlimited money, unlimited resources, like there's so many questions, but as you said, really focusing on the key questions, which I'm going to digress for a second because I know that you're doing amazing research at UVA Health. I would love to know, since you started, if there are any research projects that you can share with us that you think are addressing some of these key questions. Is there anything like that that you can share that you're working on?
Well, yeah, there's so much that we're working on, and actually, we had just received some funding to understand mental health problems in EDS and HSD, and this came from a generous donor who unfortunately had a tragic family situation where there was really severe mental health problems in a patient, and they just wanted to fund some research to understand that. And so I know what we're talking about is not directly related to mental health, but we're talking about all of these things that can be go on that certainly are taxing to someone's mental health. But these things can start early too, and go back to talking about early childhood development, but also abuse and trauma and things like that. So we're just launching into that a bit, and I mean, and there's so many other things that go on with it as well. This is a good question too. When we talk about prematurity, so there is some research that we may want to plug in a little bit further to understand more that of what we know about adolescents born preterm, maybe having some differences in autonomic function or heart rate variability, which that's relevant to POTS and an autonomic disorder. So prematurity may not necessarily explain hEDS, but it could influence some of these other associated things like autonomic regulation and other vulnerabilities that happen later in life, mental health or otherwise.
Okay. And before we move on to the next question, I want to just touch on what you were just talking about. So trauma is definitely something that, I mean, nobody goes through life without some kind of trauma, right? But there's all kinds of different degrees. Is that something that you observe more in your patients than you think the general population? And do you have any theories about that, and or ways that you address it either in patients or suggested things that people can do that are listening to this? Because I certainly see this a lot in my patients and my clients, and hear about this a lot from followers on social media, listeners of the podcast, etc.
Yeah, the short answer is we do see it more often in our patients. So that's the initial data that we're reviewing and seeing that it is coming back with higher numbers. It looks like they are significant in history of trauma and abuse for our patients with diagnosis of HSD and each EDS. Why that is that's the natural next question. I don't know. And we had at our research symposium, had one of our speakers, my colleague at Mayo Clinic, Shobha Gajrawala, who touched on this a little bit too, and brought up some interesting hypotheses about how does it tie into just susceptibility to trauma, and whether that's physical or emotional, because patients are really in kind of a desperate situation, right? When they're enduring these symptoms, they're not getting care, they're not getting validation. And so does that desperation kind of lead down? I mean, yes, we have some very fortunate situations where patients really persevere and they stick through it and they finally get the care, and really this just a miracle almost. But then obviously there are plenty that don't really, they're not able to take that higher road, and they end up really just kind of going from one bad situation to the next, and that may ultimately end up with abuse and trauma, unfortunately.
Yeah, as you were saying that, I had an interesting thought because as we've talked about before, part of the reason why early recognition is so important is because that medical trauma can really add up, right? You go to one appointment and they don't believe you, they don't listen to you, they don't seem to care what you have to say or what you suspect or anything like that, and so they end up gaslighting you, and now now you feel even worse than you did before, and now you have the medical trauma on top of everything else. But we have this conversation that you and I had in the past about uh, pain begets pain. I wonder if also trauma begets trauma. Like if you have had more trauma, does that then make you more sensitive to future trauma?
I think that's an excellent question, and I think it's a reasonable hypothesis, because I think maybe it's not even necessarily trauma that's leading to more trauma, but it's the situation that causes the initial trauma, right? And then maybe that is not being resolved, that cycle continues.
Yeah, and like it primes the brain, just like pain primes the brain also. I'm curious to ask you before we move on to the next question, if you have any thoughts about stellate ganglion blocks for dysautonomia and or for people that have had experienced trauma, have PTSD, and or any of the vagal stimulator devices.
Yeah, well, there is certainly a role for both of those. So, ganglion blocks and vagal nerve stimulators and any number of modalities too, which we've discussed previously on the show. And it's just a matter of the understanding the right setting, the right individual, and what they have and have not tried or associated comorbidities and things like that. Ganglion block is a little bit more invasive than an external vagal nerve stimulator. So we may take that, as a second or third or fourth line after some initial steps. But there certainly is a role, and there's benefit to be had from those.
Yeah, I wish we had more data about the stellate ganglion blocks. So this is where you put a needle into the neck and you're aiming for the sympathetic ganglia and you're injecting some, local anesthetic and or steroid on there to try to like calm down the sympathetic nervous system. I realized I should have defined it first. A lot of the listeners are going to know what that is, but
Yeah, makes sense now.
yeah,
Thank you
yeah,
for defining.
yeah, our listeners are very, very sophisticated. So, but not everybody knows what all of these, things are. Okay. Let's move on to the next question. So this is from Amy. She said, "So happy to have found you and your podcast. I've done a deep dive into EDS, POTS, MCAS, pelvic venous pooling, etc., because my daughter has all. I'm trying to find information on irregular uterine bleeding related to MCAS and connective tissue disorders. I think I have both, and I am postmenopausal with negative biopsy and all other tests normal. Any chance you could have a guest to interview about MCAS and EDS and postmenopause? I'm unsuccessful getting my primary and my GYN any information relating to postmenopausal women with MCAS and connective tissue disorders. Thank you."
Well, Dr. Bluestein, the guests and episode recommendations just keep coming in. So I think we have a good lineup for future episodes, and I certainly agree this would be a very good one. And I think I know a couple people come to mind. Shilpa Gajrawala, I mentioned, would kill me if I put her name out there, but she would be great. I know some others too that are in this field of women's health, gynecology, and menopause and management. And it's a very good question, and we do see these things come up a lot. I think the first point that I would say about this is that postmenopausal bleeding should always be evaluated through standard gynecologic pathways first before we think about anything else, EDS or POTS or anything else. But this is exactly the kind of topic that does deserve more discussion. So how does EDS and how do all these issues, pelvic venous issues and other gynecologic things, how do they intersect with menopause and everything else? And many patients feel like they're living at the edge of several specialties, obviously, right? When they're bouncing around between these things. So, and it's difficult if there is no single clinician putting the whole picture together. So that certainly adds a layer to it.
We've talked about menopause. We've talked about hormones. We definitely need to talk about menopause as an entire episode for sure. And I really appreciate what you said about definitely not automatically attributing postmenopausal bleeding to, one of these conditions, because you definitely need to rule out, cancer and polyps and all these other things. But we also need to do an episode on endometriosis. I would like to do an entire episode on endometriosis also because we know that this is something that affects a lot of people. I did not realize until I started seeing more patients and talking to more people about their endometriosis. Thank God this is not something that I ever had to deal with. How significant it is, how much they suffer from it. Is this something that you see a lot in your patients?
Yeah, that's exactly what I was going to say, Dr. Bluestein. And it is something I see very often, and it is very, very difficult condition. As anyone who's suffering from this will tell you, and as is often very elusive, and treatment is often unsatisfactory and prolonged. So thinking about these causes of bleeding and endometriosis and things like that, I would, and I'm glad you mentioned it because, thinking about this specific case that Amy brought up is, I think that's a question you come forward with, and we would say going to a gynecologist, how do you rule out endometrial causes as step number one? Because that is very common in our patient population. So, if biopsy was needed, was it adequate? Is there need for further evaluation with hysteroscopy, so meaning like actually visually looking inside the uterus and so forth.
Yeah, so if you've already mentioned some options, but anyone else out there, if you know somebody who would be a great guest to do an entire episode on endometriosis, like you just said, it's challenging because there are people who have, incredible expertise in that space. There are people who have expertise at, various different things, but it's that intersection that we're really looking for, ideally.
Yeah, exactly. Right, connecting of all those pieces together.
Exactly. And I'd want to say one other thing before we leave this topic, and I'm curious to get your experience on it. In my experience, perimenopause tends to be way worse than menopause. The perimenopausal period when your hormones are kind of all over the place, I think is very often worse than postmenopause when things are kind of stabilized out. And, of course, some women do go on hormone replacement therapy. Not everybody. It's not necessarily appropriate for every single person, although we know now that there are a lot more people who are probably candidates than we thought after the, women's health, yeah, all of that debacle.
Come a long
But
way.
yeah, we've come a long way, yes. So do you see that in your patients that perimenopause is just a really rough time?
Yeah, I agree 100% with you, and I think it is akin to some of these other situations where there is a lot of unpredictability, and a lot of lack of understanding. Really, is and to know, is this perimenopause or is this something else, right? And it's kind of a newer thing, so that there's sort of an algorithm you have to go through, and all the differential diagnoses that you have to consider, and perimenopause may be just looped in with the group of a dozen other things, and so it's hard to pin it down. So I would say, yeah, that added, frustration and uncertainty is a very big, difficult part of it. And I would probably get someone involved from a women's health background, gynecology background, and see to it that all of those steps are taken accordingly, whether it's other imaging or testing or just anything else that we can do to try to narrow down what are the causes at hand.
And we have a related question from Michelle that I think maybe we'll just touch on a couple of things. She asks, could you discuss the conflict between hormone therapy, estrogen, progesterone, and testosterone for menopause and EDS and how to find physicians to, she says, treat those conflicts? For example, this is her words. Estrogen is great for menopause, but not so much for EDS. Same with progesterone. Both can cause issues with tendons, muscles, and ligaments for EDS folks, but help with menopause. It would be helpful to discuss to help manage the conflict. So, yeah, interesting comment, question.
It is, yeah, yeah. Thanks, Michelle, for asking that. And you know, I I would I would start by just validating the conflict, right? And it's there and it's real. And this is an important question because it captures what many patients experience, that menopause symptoms may improve with hormone therapy, but some patients with EDS or hypermobility feel that certain hormones worsen joint instability. And just like we were talking about pregnancy, yes, majority of patients do just fine, and some but some may have complications that we didn't expect too, right? And we might have not thought that it would be really a great concern. So I think that it's not just a blanket yes or no answer. And obviously that adds to more tension for the patient, and it deserves really thoughtful conversation.
And the only other thing I was going to add to that is just to be aware of clinics and practices that are never or always. So, there's clinics that are always going to prescribe hormones. I mean, I say that they're like just selling hormones. They prescribe hormones to everybody. And then there's other clinics and practitioners that never prescribe them. And what you want is somebody who's thoughtful, who's really going to look at, your various risk factors for different cancers, your family history, the symptoms that you're experiencing, and really make a very thoughtful, obviously with shared decision making, very thoughtfully go through and assess what would be best for you.
Right. And it's just that, as I mentioned, it's hard to say it's just a yes or no answer. And even like, hormone and estrogen for example, I would be careful saying that estrogen is universally bad for EDS because there are many important benefits for menopausal symptoms, hot flashes, sleep issues, all this number of things that we've had, as you mentioned, have had greater and better application for. And I worked with some very good menopause doctors at Mayo Clinic, and they'll be the first to tell you that it really is the most effective treatment for vasomotor symptoms and other genitourinary symptoms of menopause. And certainly risks do vary from individual to individual, and those all have to be considered closely.
Yeah, and estrogen is helpful in moderation for tissues. I mean, if, your skin and you know your connective tissue. So yes, I appreciate that you pointing that out. That the comment that estrogen is bad for EDS is not. It's I wish more things in medicine were clear cut, but
Yeah,
it's
right.
usually most everything is
Yeah.
very nuanced,
Well,
right?
we're in the wrong field if that's what we're looking for.
Yeah, good point.
Yeah. But it's good. But that's why we do what we do, right? Because we're
Right.
interested to learn more and share our knowledge.
Yeah. No, that is an excellent point. Okay, so our next question is from Amanda. She says, "Hello, I'm a nephrologist who was recently diagnosed with Ehlers-Danlos syndrome after a complicated history with multiple bowel obstructions over the past 3 years and now bilateral vestibular dysfunction. I've found there's a lot of misunderstanding and misinformation out there about the condition, but your podcast is a breath of fresh air. I'm interested in how to become a better advocate for others and myself to learn about the disorder. Is there a better way to communicate with you? Thank you for your time." So, Amanda, thank you for your question. And is there a better way to communicate with me? I wanted to mention a couple of things. So, this is exactly why I started the podcast, the Bendy Bodies podcast, so that we could share information with a wider audience, and people can listen and re-listen, and they can access the transcript. And I shared this hack before. If you're limited on time, take the transcript, stick it into AI, copy and paste it into AI, and ask AI to give you a summary. Especially if you have a particular background, you can ask it to give you a summary based on that. So, I started the podcast for that reason, and I know that there are so many clinicians that listen. So that's, really reassuring to me. When I went through the questions for today's episode, even there were so many questions that were from clinicians, which is really great to see because, of course, they can affect, even more lives. I want patients to listen also, but it's really great to have that. And also I morphed this into the coaching aspect and the mentorship and things like that because, there are a lot of people out there who would like that kind of help. Of course, there are also the EDS Society ECHO programs, and I know that you do a lot of education through UVA Health. Dr. Knight, are there other things that you want to share that ways that people can learn?
Yeah, and I think you're exactly right, Dr. Bluestein. It's the multiplier effect, right? That we want to reach those who will reach as many others as possible, and yeah, physicians and other clinicians are a great bridge for that, and but also patient communities too. We're just talking about social media, so hopefully, there's social media discussion forums are coming forward from some of the better resources and knowledge that is out there. The EDS Society has ECHO programs too, global learning conferences and things like that. Those are very good sources of information. There's any number of research studies that you can stay engaged with. And you mentioned AI tools. I think that's another good way of using it. If the research article is too dense for you, just plug it into your favorite model, and you can get a kind of a summarized, more understandable, reachable version. So I do appreciate Amanda's comment here because I think that as a physician yourself, then it must be very validating and frustrating at the same time to experience the diagnostic journey from the patient side, but also being up against the barriers that we know are there and are real for your own patients, and it's very difficult, and I can certainly sympathize with that.
Yeah, I have a shocking number of, nurses, uh, physicians, physician assistants, nurse practitioners, et cetera, in both my coaching practice and as patients. And I can't tell you how many times I have heard, if I am having this much trouble navigating the system, if I am having this much trouble with gaslighting, how is a non medical
Right.
person supposed to cope?
Right. Exactly. It is terribly frustrating. Yeah, you said it perfectly. I can imagine that the times I'm banging my head against the wall and just not making any progress with other clinicians and specialists that I'm trying to get patients to be helped by. And if I'm running into that, goodness knows that it must be so much more difficult for the patients themselves.
Okay, next question is from Lilith. And remember, submit your questions, bendybodiespodcast.com. We would love to address your question on the next episode. Okay, so Lilith asks this question. I recently had a kidney auto transplant for Nutcracker syndrome. I received TAP blocks for post procedure pain management. I received the TAP block right before I was wheeled into the operating room. And as I was being set up for surgery and put to sleep, I tried to tell the people around me, the nurses, anesthesiologists, etc., that my tongue was feeling numb. After surgery, I woke up from surgery. I continued to experience tongue numbness, which seemed to worsen each time I received oxycodone, alternating with Tylenol. My tongue was not visibly swollen, but felt swollen. I also experienced tongue numbness when I received a hilar renal block that was done as part of my workup for Nutcracker syndrome. In both situations, I let healthcare providers know what I was experiencing. In the case of the renal hilar block, they suggested that maybe some of the block or local anesthetic had entered my body. I imagine she means bloodstream, as they saw a drop of blood and thought that I was experiencing a vasovagal response. And in the case after my Nutcracker surgery, no one knew why I was experiencing tongue numbness. What could be the cause of this? It's made me more cautious with receiving blocks of any kind.
Well, and I will certainly turn to you from the anesthesiology perspective, Dr. Bluestein. But I will just say at least a couple of things to start is that I can understand why it makes someone cautious about future nerve blocks and going through all these things. Tongue numbness during or after a block is not something I would dismiss, and especially if it's happened more than once after procedures for local anesthetic, and so. I think, yeah. What you had mentioned. So, if the local anesthetic is entering the bloodstream and causing some systemic toxicity, that would be very concerning. And maybe there's something going on there. If there is numbness or sometimes even dizziness and other neurologic things may happen. I'd say that there's a lot to be considered here.
Yeah, and I want to add to that. So, yes, exactly what you just said. So, LAST or local anesthetic systemic toxicity is something that probably occurs a lot more commonly than most of us realize because if you've received midazolam or some other benzodiazepine, that actually kind of suppresses that response. And so you might actually have more of an effect and not be as aware of it or be able to tell the team as much as if you don't have that. And some of the things just to be aware of that can occur with LAST, tongue or perioral numbness, exactly as she describes, metallic taste, tinnitus or ringing in the ears, dizziness, agitation, slurred speech, seizures, or cardiac symptoms. And then it can progress to like life-threatening symptoms if the blood level's high enough. But I imagine that like most things, it's on a spectrum, and there's probably a lot of people that experience some mild symptoms related to this that we never pick up on because we're not looking for it, right? If we're not looking, we're not going to find it. So I think that it's also interesting because I had a similar reaction a number of years ago. I was working in the OR and somebody said, "Oh, I can inject your knee." And they were basically doing it between cases. And I didn't calculate my own dose of local anesthetic properly. And I gave them a syringe and I said, "Oh, here." They injected it into my knee. And I immediately, I was in the PACU and I said, "Oh my gosh, I need to lay on the floor." And I laid on the floor, and afterwards, everyone was telling me that it was a vasovagal reaction. And I'm like, I have had vasovagal reactions before, and this was very, very different. This was definitely not that. I feel very confident in my case also that it was last. So I think a couple important points here are one, size matters a lot. So, like I said, I should have calculated my dose more carefully. I kind of just went with like the average dose for an adult male. And at that time, my weight was even lower than substantially lower than it is now. So like I should not have given him that big of a syringe. And also the condition of the tissues makes a difference. So I had a lot of inflammation in my knee. And so the local anesthetic uptake is going to be a lot faster. So there's a lot of factors that can
There's like
contribute to
increased
that.
permeability going on and things
Exactly.
like that, right?
Exactly, exactly. So the whole thing with the oxycodone is kind of interesting. Maybe there was some histamine release related to the oxycodone. Maybe it contributed also to dry mouth or something, and maybe that's why that seemed to be related. And or it's possible that, she made that connection, but it was more, random than that. But it's really important that people be aware of these things because I feel like blocks are becoming more and more common. They can be hugely beneficial. So that's the other thing is, I hate to see somebody saying no to blocks when maybe if they were done, with the correct dose and, more, cautiously because if the person says, look, I had possible early last or systemic effects last time, can we think about the total dose? Can we think about adding epinephrine, which will decrease the absorption? Then maybe that's something that should be considered in the future. All these facilities should have something called lipid emulsion that they can use to reverse the effects. But this is a great question because this is something that probably has occurred to other people and they just don't necessarily know, what it was, and they may or may not have brought it to the attention of the team.
Yeah, no, I agree. I love to hear your insight on it too, Dr. Bluestein. And speaking of personal experience, if you got it mixed up, then you can imagine others might, right? So, and yeah, I agree with you. I think that this doesn't necessarily mean the patient can never receive a block again, but I think that it definitely belongs in their anesthesia history, in their medical records, so that that can be attended to if it is something that is recurrent, and it may involve pre-procedure anesthesia consultations in the future. So careful dose planning and all the rest.
And the last thing I want to point out about this is that it is not at all uncommon to receive a block before the procedure and then get some local anesthetic during the procedure, and those can be additive. So it is very possible that maybe she was having a little bit of symptoms, then they induced general anesthesia, and maybe she got some local anesthetic during the procedure or at the end. We often put in a lot of local at the end, and the surgeons will often be very generous with that because they want you to wake up and feel, at least from the standpoint of the incision, fairly comfortable. So those cumulative doses also should be considered and, taken into consideration.
Yeah, definitely.
Okay. Well, I loved getting to talk with you about these excellent questions. And hopefully, we'll have some really great ones for our next conversation. Before we go, is there anything else that you wanted to share? Anything else that you're working on, or any developments that you want to share?
Well, I one would say yes, very much enjoyed it too, and I hoped it helped some of our listeners. But I think sometimes these things generate more questions than they answer, and I love that though because there's definitely a lot of very good questions here to address. So definitely looking forward to coming up with some more fan mail that we can go through in a future time. And yeah, please keep it coming.
Absolutely. Okay. Well, it was great chatting with you, Dr. Knight, and I hope all is well there. And I'm sure I will be seeing you in the very near future in person. I think the EDS Society Global Learning Conference, which I'm not sure what the release date is going to be on this episode, but we're recording it anyway before the Global Learning Conference. And I think that's going to be the first time I've met you in person.
Okay. Yeah. Great. All right. Looking forward to that for sure then. Yeah. It's a long time coming then.
Yeah, which is kind of crazy. It's funny, now we do so much virtually that
I know.
sometimes those things happen. So, okay, well, thank you again.
Yeah. Thanks, Dr. Bluestein.
I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Thank you for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about these conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, my passion is helping people better understand and navigate symptomatic joint hypermobility. In addition to my clinical and educational work, I offer one-on-one coaching, professional mentorship for healthcare professionals, and expert witness services. If you'd like to learn more, please visit the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at Hypermobility MD. As part of our collaboration with the UVA Health EDS and Hypermobility Disorders Center, we also want to share a few helpful resources. For questions or appointment inquiries, you can contact them at ruvaedscenter@uvahealth.org. That's the letter R, UVA EDS Center at uvahealth.org, or call 434-243-8200. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. We love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect my views or opinions. Furthermore, perspectives expressed within BendyBodies media, including this podcast, do not reflect the views or opinions held by Human Content, Inc. Although we may share healthcare perspectives on this podcast, no statements made on BendyBodies should be considered medical advice. Listening to or watching this podcast does not constitute a doctor-patient relationship. Please always consult a qualified healthcare provider regarding your own care. For information about the BendyBodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. BendyBodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the BendyBodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.